Hey everybody, it's Matt here from OK Aussie and welcome back to our channel. I'm without the Di. She's resting up in bed just over there, but I do have the budgies behind us, so they might participate a little bit in this video. Now, today's topic I want to talk about is what we, Dyan and I, have actually been doing over the Christmas period in between moving, which you know we've been doing that, and settling into a new location, whilst dealing with her very complex chronic genetic condition, 22q11.2 deletion syndrome. And that really, that label, that thing there is what I want to talk about a bit today, because our channel is really a channel that is out there to educate, to inspire, to create awareness and assist in facilitating better care outcomes for people with 22q11.2 deletion syndrome. So over Christmas, I set myself a bit of a project, and that was to scour the internet, which is partly really my background as a online internet marketing expert for 25 years. I know how to search and research, and with multiple degrees, I know how to analyze information, to compile it. And that was really my journey, was to explore what's out there in regards to the medical literature, medical journals, clinical guidelines, and what people are talking about. Are there organisations out in the ethers of the internet? What do the hospitals provide as far as information worldwide? Because I wanted to source the very latest information and get a clearer picture of what people understand that 22q11.2 deletion syndrome is actually about. Now, we show Dyan's daily living activities, okay? Real, raw, it's very transparent, sometimes a little bit confronting. So sometimes we put a trigger warning out there too, because she's dealing with some very severe complexities around this condition. Now, it is a spectrum, like many conditions. You could have the condition and have no symptoms, fantastic, all the way up to the other end of the spectrum where you have the worst case scenario and all of the different symptoms, and it can be life-threatening, life-limiting, or life-terminating. And that's something which has actually come out in the research. My goal was to find all the information and bring it together to create and build a library, a reference library, a research library, a resource for Dyan, her primary care physician, the multiple specialists. Dyan's got 22 different specialists, ologists as we call them, you know, the neurologists, the cardiologists, the gastroenterologists, the rheumatologists, they go on. Okay, there's a lot of ology involved in being a specialist to manage and maintain the condition. But this journey that I was on was inspired by the fact that we do not have a singular specialist with knowledge and capability around 22q for adults where we live in Perth, Western Australia. In fact, across all of Australia, there's really only 2 locations that have either a clinic that actually manage and support adults with that condition. We do have a children's clinic at the Perth Children's Hospital where there's 2 specialists, but that's for children, 0 through to 18. And once they migrate into the adult sphere, there is nothing available for them, unfortunately. So that's very difficult. So bringing a library together, getting all the latest research, creating a very clear picture of understanding of what 22q is, what all the current research by the geneticists and specialists in different fields as they start to explore the condition and learn about, has been very insightful and very powerful, and altering the information that has been told to us along the way. Misinformation, misjudgment, misnomers, because not everybody is up to date. In fact, there's a lot of medical professionals, and the literature actually backs this up, who have not come across a patient with this condition. They may not have actually heard about this condition at all in any of their years of medical study or in practice. So that's interesting. So I want to bring together in this episode some of the facts, some of the information for this particular genetic condition for Dyan, and how it relates to her, and why we've gone through this process, what we've learned, and why it's beneficial for you if you're a caregiver, a partner, a parent, a friend of a person, or the person themselves who've got this condition, who wants to learn more. And it might also inspire you across other conditions, other genetic or chromosomal disorders or rare conditions, to also explore and become informed, to educate yourself about what's out there in the literature, what's happening, what new tests may have evolved, what new treatments may exist, what research can be participated in, what organisations there are that you can connect to get support and help and guidance, to connect to the right people, to feel not so much alone, but now informed, empowered, to be a part of your own health condition and assist in actively asking the questions that are relevant to your experience and the symptoms, and to stop the gaslighting that commonly occurs. Now, unfortunately, with a lot of rare conditions, it normally takes at least 10 years to get to that point of discovery through testing to actually get to a diagnosis. Now, that's 10 years of a lot of suffering, a lot of struggles, a lot of stress, a lot of strain to reach that outcome, to then first of all get that knowledge. But then once you've got that diagnosis, what do you do with it? How does it help you? Does it help you? Because in some cases it may not. In our cases, for Dyan, when she finally achieved the diagnosis for 22q, the geneticist said, Google it. So we had to. And we found a lot of varied information out of there. And there was some biased information depending on research pathways as well. But when you dug deeper and realized this is actually very complex, it opened our eyes. So let's go back a bit. Dyan, who's now 50 years of age, has born with a genetic condition. She didn't know it back then, but she knew there was something different going on. So did all her family. They knew she was very sick, autoimmune compromised. She struggled even prior birth. She was born extremely premature in a humidity crib, in intensive care for newborns. She struggled with eating and feeding. Her growth was impeded, failure to thrive. So she's very small in size. In fact, by microcephaly, she has one of the smallest head size by standard deviations in the female population. So there's not much room up there in that big brain of hers, and she's very, very intelligent. But at the same time, there was a lot of things noticed by family, by educators, by medical people that said, hey, there's something different, something going on. I'm not quite sure what it is. So she got individual diagnoses, and that quite commonly happens. Autism, ADHD, OCD, autoimmune compromise, very sick, bit clumsy, educational delays, intellectual delays, didn't speak for a long time, mute, selective mute. So surely that would have painted a picture that needed more investigation. And maybe there was the era, maybe there was a lot of other factors involved in it. But let's get to the research and why we've done this over the Christmas period. So I've explored the internet everywhere, okay? The internet's a big place. And have read well over 1,000 different articles, medical journals, clinical guidelines, specifically around 22q11.2 deletion syndrome, and some of the earlier naming nomenclature that was actually used, because there is a range of different names that was used for the condition originally, and that quite commonly happens. They get named after, a bit like an inventor, okay? They get named after the person who discovers or puts together a series of symptoms and says, hey, people with these combinations of symptoms have this condition. So in the old days, it may have been called autosomal dominant Orpitz, GBB syndrome, catch-22, Kayla syndrome or Kayla facial cardiofacial syndrome, contruncal anomaly face syndrome, CTAF, deletion 22q11.2 deletion. DeGeorge is probably the most commonly named. Salakvova syndrome, Schwitzen syndrome, Villocardiofacial syndrome. So you see all these individual names. But what we've realized that all of these things are the same thing. They just didn't understand that until the advancements in medicine occurred. And we're still at really the infancy of the advancements of medicine. They can't recreate the human brain. They can't rebuild a human heart. They can't make a human from scratch. And they really only know smallest components about the functional capacity, and they're trying to piece it together, and particularly with the area of genetics. And that's really important because your genes, your DNA, are the building block of life. Now, in Dyan's case with 22q, it's a micro deletion of the long arm of the 22nd chromosome. We have 23 pairs of chromosome. The 22nd is one of the smallest chromosomes, but it's got a lot of impact when you're affecting it. And a micro deletion means that she's missing a small little chunk on the longer arm of that 22nd chromosome. That's about 3 million DNA building blocks that are missing. Every single gene, every cell in her body is affected in some way. She's effectively missing around about 30 to 40 actual genes. And some of those genes are very, very important because they perform certain functions, particularly anything in the midline that hasn't formed correctly during the early developmental phases. So we get quite commonly the cleft and cleft lip, cleft palate related issues, midline issues such as maybe nose development, spinal development, heart. Okay, so with this condition, it affects about 180 to 185 different clinical symptoms whole body wide. That's a lot of things to deal with. And we break those down into a lot of separate individual symptoms. A bit like I was telling you about that Dyan found early on in childhood. You've got autism. That's because of 22q. In fact, about 25% of patients with 22q have autism. You've got ADHD. Well, in fact, about 40 to 65% of people with 22q have got ADHD. You've got OCD. You have seizures. In fact, about 65% of people with 22q will have some type of seizure or seizure-like disorder. That's a lot. Skeletal issues such as scoliosis and improperly formed skeletal sections, particularly with things like the CCI, cranial cervical instability. And the list goes on. Every part of her body can be affected, and for Dyan it actually is. And there can be late onset parts of it as well. So what happened with this research? The research, first of all, really clarified around the naming, the nomenclature, why we should call it a certain thing. So in the early days, we get it. People were still trying to work out what this condition is. Now there's a correct terminology. The term DiGeorge is now reserved for individuals who have the clinical features but have yet to undergo genetic testing and actually get it confirmed. Once they've actually used things like the FISH test, fluoro testing of the cellular level for DNA, now researchers have found the unifying cause for patients with deletion, and they can collectively be referred to as the chromosomal etiology of 22q11.2 deletion syndrome. And that's what we encourage everybody to use, the correct naming conventions as they move forward. Or if they've still got the old names, go and get appropriately tested or updated with the testing of genetics to find out what's actually going on for those people. Dyan was diagnosed about 1.5 years ago at King Edward Memorial Hospital here in Perth by a geneticist. That was on the 21st of the 7th, 2023. And this is the other part that would inspire me to go off and exploring, because almost 1.5 years after being diagnosed, and we knew all before that there was issues that we were reaching for. Remember, how do we get to that diagnosis journey in the first place? I had to go off and explore and find other ways to get explanations to why there's so many different individualized symptoms that just weren't being picked up by the medical community here in Perth, Western Australia. We did our own genetic testing by reaching out to a genetic source, 23andMe, and we actually were able to extract that genetic blueprint and put that into an online genome research application, LiveWello, which opened up our understanding that there's a lot of issues with certain genes, things that were missing, things that were affected, particularly in family history, genetics passing down, okay? And with 22q, you have a 50% likelihood of passing it on to your children. Only a 10% de novo, which is something that's discovered without any influence from the family relationship, okay? So that was very important to understand. And when we realized that, look, there's some explanations tied into genes, we really needed to get some answers. I got the tape measure out and started looking and going, well, if we look at some genetic conditions, do you have any of the familiar facial features or symptomology or issues that others do? And we did find that. I was measuring, I was looking inside her mouth, I was checking the shape of her ears, I was asking a lot of questions about family history, because that's really important. What have others in the family done? So we built a really big profile about family history. And if you haven't done something like that for yourself, do consider actually documenting your own medical history, your family medical history, getting genetic research done if you're able to do that. And always remember to collect and maintain all your reports, all your tests, whether it's pathology, blood tests and urine samples, radiology, x-rays and CTs and MRIs, and also discharge or exit summaries from ED presentations or clinic appointments. Keep all that together yourself so that you can actually build the profile and have all that information on hand to learn. Because after going through all the online research, I have 3 of these folders totally full. Okay, that's hundreds and hundreds and hundreds of reports and research and documents and guidelines about the condition that I've downloaded to then analyze and look specifically at Dyan and go, okay, well, what's happening and what's changed and what's new and what do we know? So let's go back a step. She got diagnosed on the 21st of the 7th, 2023. We were told to Google it. She was sent a pamphlet in the mail which actually had abortion information on it. Now I know, look, being very raw and very shocking, for a person to receive that, to say, hey, look, really, you probably should have been aborted, tells you a lot too. It's actually very hard hitting, very emotionally going, oh, I'm not seen as worthwhile, I shouldn't have been born, no wonder my family didn't want me. Because remember, Dian's an orphan from her family who couldn't cope with her very complex medical conditions. They didn't get her help, they just abandoned her, and that quite commonly happens as well. Even along the way, you do lose friends and family and connections because of the complexities of a complex health condition. And particularly when things aren't understood, or there's impressions put upon you that you're just not good enough, you're not trying hard enough, that you're weak somehow, or that you're fake, that you're just pulling it off to get attention, for example. That so commonly is actually said to females. I can't believe it, but I hear it so often and I've seen it firsthand. In fact, there is already, as we know, very much a male misogyny in the health system, particularly here in Australia, and I'm sure internationally you've probably seen that anyway. Females really get it a lot harder. Me as a male, if I have sudden chest pains, you know what? They'll rush me in, they'll put leads on, they'll think I'm gonna have a heart attack. For most females, however, 75% of the time they won't do the same thing, or they'll discount and go, just a bit of stress, just a bit of anxiety. Even though you might be the same age and the same weight and have the same lifelong experiences, environmental exposures, it's treated differently between male and female. Now that's not acceptable, it's not good enough, and it also makes a huge amount of mistakes because it's assumptions. It's a huge amount of assumptions that go on. Then there's other things that come into it culturally and even biologically. If you're small in size and people are bigger than you, and they stand over you, it can be very intimidating. Males can be very beaming and broad and strong and dominating. So there's that sort of psychological balance between the engagement and communication styles, and that affects interactions for people as well. So I'm pointing these things out because all of these things are an influence, particularly when you're engaging with healthcare or medical, or the people around you believing you to understand your condition. I actually find it's unbelievable that people didn't get it and try harder and have a look to actually explore, to work out what's going on. Surely no one can have this many conditions, this many symptoms, this many issues without there being actualized problems. Well, there were, and we found them one at a time to actually build up that profile. And it really was probably only about 7 or 8 years ago when I stopped working, saying, this is stupid. I've had enough. This is not fair. This is not right. There's something definitely going on, and she's being failed. She's been failed by the healthcare system. And look, I've heard so many people worldwide, particularly on our channel, in the comment sections, who engage, who connect, who have very similar experiences, who've been let down by the healthcare system where they happen to be. And I feel sorry for you, and I'm so sorry for your experience. I know this firsthand as a caregiver, as a partner, as a guardian. I see it. I've spent years of my life sitting in clinics and in hospital EDs, hearing the behaviour and seeing the behaviour firsthand. So I get it, I understand. Well, now we actually have the answers for Dyan, and genetic testing has given us that blueprint, and the clinical guidelines gives us the direction to know what needs to be done what's understood and recommended as best practice worldwide by the international specialists, the actual doctors who have been dealing with patients exactly like Dyan with 22q11.2 deletion syndrome, who might have had hundreds of exposures to patients in their clinics. And collectively, there's some really good organisations who have come together and have brought these specialists, these experienced people, these clinicians with this knowledge, and who've been part of working groups to actually write up the medical literature, the medical journal articles, and then develop and evolve the clinical guidelines involving multiple countries. So there's quite a few groups now that have actually started to do this and present this information. My question that always arises from that is, why are we reinventing the wheel? Why do we start and go back and pretend there's nothing happening when all this good work, this foundation has been done and created by experts in this field, by people who are working with hundreds of patients, who therefore have got a very good overview of the experience of hundreds of patients in that cohort of 22q to know what they're doing. I'm sometimes baffled, but sometimes that's the stupidity or the arrogance that appears with medicine and the medical field. They do need to look at what's been done before and bring this information together. And I've seen now 3 separate large scale reports who have actually scaled the entire literature, just like I have as a lay person. They've reached out and gone out and looked at and collected all of the articles that mention not just 22q deletion or duplication syndrome, not just DiGeorge or catch-22 or Kayla function or chronotruncal or Stadalaka or Spritzen or velocardia. They've looked at and brought together all those articles just like I have and summarized them to work out, are they repeating other people's work? Are they individual sort of work? What year were they done? What were they focusing on? What area of speciality? And bringing all that information together with some very, very clear pictures, and that's what this video is about today. We've had some good learnings from that. We shouldn't reinvent the wheel. We should realize that there's some really good research out there. And when specialists don't know, when doctors don't know, the first thing that they should do is say, I don't know, but I'm willing to find out. I want to work with you to help you and explore and learn about this condition. What do you know? Asking questions, opening up the conversation, working in conjunction with the patient and the caregiver. And that's actually a very important part too. And I'm going to read some of the summary parts of what's important for clinical allowances that doctors and specialists and hospitals should actually think about. It ranges, 22q, from mild to severe. Just because a person doesn't present with any particular clinical symptoms doesn't mean that they haven't got the condition. It doesn't mean it won't affect them later in life. It's a variable clinical phenotype. Medical professionals are often unaware of 22q. A lot of people know about 21q, okay, Down syndrome. That's the partner in chromosomal disorder. A lot of people know about that because it's quite openly advertised and talked about. But there's a lot of conditions that people don't know. And look, we know that there's several thousand rare conditions that exist out there, but they don't get the time and the attention unless there's money behind that, particularly in areas such as big pharma, pharmacology. If you can't make money out of something, will they invest money? It's a business practical, okay? We get the logic behind it all, but it doesn't mean it's fair and or right. So that means a large cohort of people can slip under the radar, get missed, be ignored, or not have enough research done. Communication and cognition issues in 22q affect medical management. In fact, deficits for the patient in their language comprehension can be camouflaged, masked particularly in the area of autism, female autism. They're expert at masking, pretending to be something which they're not. They've learned socially by watching TV how they should act. We talk about this on our channel a lot. Dyan will go to the doctor and he'll ask the very first question, how are you? You say, oh, good, thank you. And I'm just looking at him going, what do you mean you're good? What planet are you born on? Seriously. Did you not remember you had a migraine only 2 hours ago? Did you not remember that you had massive seizures only yesterday? Do you not remember that you had a XYZ the day before? But this is the social engagement model we tend to shrug off. Males are actually even worse at that because they tend not to go into feelings or thinking that they might be weak by exploring and explaining, oh, I've got a headache or a migraine, okay. Or they might be concerned that if they admit that it affects their well-being, jobs and opportunities, relationships. So you've got to understand that people don't always have the ability to speak and express that. And particularly when people have got intellectual developmental delays, global developmental delays, communication developmental delays, okay? People like Dyan, how does that make that easy? She was mute, selective mute until about 11 years of age. I've seen her go selective mute at 50 years of age. How does she navigate those sort of circumstances, and how does your person, a person with 22q, manage that? So coupled with a tendency to downplay, hide or deny existing problems, as well as the difficulty engaging during a first meeting, medical history taking can be challenging. Most appointments are given to people 15 minutes. If you go to a specialist, you're lucky to get a half-hour first sort of appointment. That's never enough time, because you've got to slow things down. You've got to speak one thing at a time. You've got to allow for it to be processed, to be understood, for an answer and a response to be formulated and then expressed, which might be slower than the person has the patience to wait for. We have to slow these things down. So we can do things as a caregiver or as a partner, as a family member, to assist in all that. And that can be actually collecting a lot of these things beforehand, documenting, asking the questions, being prepared, even doing social stories so the person knows what to expect in an appointment so that they can actually be more effective or efficient. Or understanding, as the medical literature says, that you need to involve that caregiver, that parent, as part of the conversation to be effective. Now, patients, along with collateral information from caregivers who know the patient well, can ameliorate these issues. However, more time and more investigations than are necessary for the average patient are often required. So you've got to allow that. We've got to the point this year now where we're setting up an hour-and-a-half appointments every 3 weeks with Dyan's primary care physician, because it takes that long to get through the huge range of issues. Now, in your experience, if you've got one thing to deal with, then it's not as much time and effort that's required. But when every part of Dyan's body is affected, where do I start with the list? Oh, I've got my eyes, I've got my ears, I've got swallowing problems, I've got a migraine, I've got a sore neck, I've got a sore back, I've got this dislocation, I've got this thing here not working, I've got chest pains, I can't breathe properly, I've got edema, I've got seizures, the list goes on. But each one of those are individualized. Some cross over and work cohesively together, but you need time to explore each one, the symptoms, what's causation, what management's required. That means time, okay, time. So similarly, the cognitive capabilities of patients with 22q to describe or to understand their various medical conditions they have and the need for treatment for these conditions may be suboptimal, especially in the presence of intellectual disability. Standard measures to improve compliance with recommended management can include clear and careful explanations to the patient together with caregivers. One of the things that I have discovered along my journey, next to Dyan, going to clinics and medical appointments, is that there is a massive failing in the clear communication and the understanding and the provision of information and guidance on what something is, why it's occurred, what needs to happen, why we need to do these steps, and then what to look out for once you start these steps in case something else happens. Commonly missing. Sometimes you're just given a script and it's like, what's this? Oh, a script. Oh, thanks. What is that script? What is on it? What do you expect as side effects? What's good or bad side effects? What's okay to deal with but not okay to deal with? When should I raise the flag? When should I ask more questions? When should I come back? Do you see the issue? Just by giving a script but not filling in all the gaps? That's stupid. And you're dealing with a person who needs that extra information, that explanation, and that time to explore and understand that. Take the time. Providing simple written instructions and monitoring medication intake is often helpful. In our own home and own engagement, we have to slow things down. If I have to give one instruction at a time, make sure it's understood, wait for it to be applied before I then give the next, then the medical people need to do the same thing, because otherwise it's going to become constipated in the communication, and that's not going to be a good outcome, is it? Outcomes in older adults for 22q. Information about the long-term outcomes and older age ranges in 22q are very limited, okay? Most reports involve individuals only in their mid-30s on average. Dyan is 50 years of age. So what that means is a lot of the research is quite young still to date. We haven't got longitudinal studies. We don't have people at 40, 50, 60, 70, 80 or 90 years of age with their data coming back in to look at each of those different changes and evolutions in the condition over periods of time to understand what happens, what to expect next in those later stages, but we know that deterioration occurs. Premature mortality in this condition, that should be something to worry about, because I am. I'm very worried about it, because I've held Dyan's life in my hands several times, resuscitating her. I've been involved in many emergencies with her. I'm dealing with aspiration or choking, breathing related issues, heart, cardiac related issues, anaphylaxis related issues, seizures, let alone trips and falls and everything else in between. That can be quite scary for a person who might be a family member or a relation or a friend or a neighbour to deal with these things first up. So even those people might struggle with how to deal with it, and they want to find out more information, and this is what we're doing as well. By educating, by knowing how to manage it, we feel more comfortable, more competent, and the people around us, the caregivers, because Dyan's under the NDIS, the National Disability Insurance Scheme, and because of that, we're in disability housing, we have a disability support team, but even they are not trained, okay, even as nurses, if some of them might have nursing degrees and qualifications in this specific condition, and what to look out for and how to manage that. So they've got some basic education. We still have to inform, and bringing this information together helps them to actually understand the condition, what to look out for and what to expect. Okay, makes her life better. It accepts where she's at, what she actually needs, and enables her to perform at her peak. Okay, common sense. So the mortality part, individuals with 22q who survive childhood. This was one of the big takeaways I realised in the research, is there's not enough information on the fact that so many patients with 22q didn't actually succeed in being born. In vitro, they failed, okay? And that's quite commonly, particularly with the cardiac-related genetic conditions that can occur in those phases. But the data doesn't include a lot of those stats. So that creates a misnomer in the actual statistical data about how many have actually survived. A lot don't actually get to childbirth, or they struggle in the first 1 to 2 years and may terminate. So for individuals with 22q11.2 deletion syndrome who do survive childhood, there seems to be an increased risk of premature mortality in the adults. It's not attributable to any one singular identifiable factor, because just like I said with Dyan, could it be a heart attack that takes her out? Could it be the fact that she chokes while having a seizure in the middle of the night? She bangs her head on the way down because of a fall. Could part of her heart do something weird I don't know. Okay, we don't know what possibly could do so. We just know there's so many risk factors that we're dealing with. The median age for patients with 22q for death is 41.5 years. 41.5 years. Dyan's 50. We have seen exponential deterioration in her condition. We're seeing over 22 different specialists for different parts of her body, which are all compartmentalized, not cohesively working cooperatively together to understand the impact on their clinical decisions and medication choices, etc. That's a lot of people, a lot of areas, a lot of elements, a lot of aspects, a lot of concerns. There's no surprise to me that why there's so many sudden deaths. And look, the severe symptoms can lead to a shortened life expectancy without treatment. It remains unrecognised despite the prevalence. It's actually one of the most common chromosomal disorders that exist in the rare category, and yet it's one of the least known. How can that be? How can you have something which has got such a large prevalence and yet it's so poorly understood and so poorly known? Too complex? Way too hard? It's not just a couple of symptoms. Okay, well, a couple of symptoms we could deal with. 185 different individual symptoms. That clouds the situation. That makes it far more complex. So previously it was known as DiGeorge or velocardiofacial syndrome. It remains largely unrecognised in adults by both healthcare and society at large. I mean, I've done this test. People ask me, what has she got? I go, 22q11.2 deletion syndrome, and they go, what's that? It's a genetic condition. It's a chromosomal disorder. It means that she's missing parts of her, building blocks. Genes are missing. I still don't understand, because a lot of these are technical terms, and I get that lay people may not understand the language that's inferred around this. So sometimes we have to do relative examples or give explanations of some of the symptoms. I say, look, it's a very complex condition. It affects her entire body. Okay, it means that she can have all these different types of seizures. She's autistic and ADHD, and she has Tourette's, and her spine's not working, and her heart races from as low as 30 all the way up to 230. She sometimes can't breathe, and she's only getting 70% of oxygen coming. All these different things. So you're trying to explain it in a way, or you go, well, you've probably seen and heard about Down syndrome, haven't you? What's the 21 chromosome? So you give examples. You try and make it palatable for them to understand and comprehend. But I still get blank looks. I get it, because it's not known in the literature. People don't talk about it, and that's why we're having these discussions. That's why we're educating, by creating awareness, by having conversations, by people talking more and more about it. We will find that people have an understanding and a comprehension, or you can characterize. A lot of people in society know about cancer. My mum, many relatives have died of cancer along the way. Many people also survive from cancer. I think the mortality rate these days is probably only in the 15 to 20% for cancer. I've had one doctor explain it to me and say, well, it's like having cancer, but it's also then like having this condition, and this condition, as well as the cancer, at the exact same time. And it's like, oh yeah, well, that's probably a good explanation, because then it shows it's not just this bad one, but it's all of these things simultaneously. Sometimes you have to paint the picture, otherwise people go, oh yeah, I've got that too. It's like, what? As in, you talk about single aspects like of fatigue. These conditions create huge amounts of fatigue. I mean, Dyan spent years in bed, not actually getting out of bed. Sometimes not getting out of a bedroom, not seeing the entire house, let alone getting outside of the front door. So you lose a lot of life. That's why you lose also a lot of friends and family, because you're not fun to be around sometimes when you're sick. Sometimes it can be quite depressing. Okay, well, how about being a bit more empathetic, a bit more supportive, a bit more caring? That's judgmental, and understanding that's not their fault. They don't choose to be born with a genetic condition, do they? They're trying really hard, I know Dyan does, every single day to put on a bright face, to bear through the pain, which I see tangibly is so real, very intense, very, very strong. Now, ongoing care in 22q patients. This is the part that really bugged me, because recently we've had certain specialists that say, oh, no, it's something I need to see you for. You don't need to come to this clinic, or you don't need to come to this speciality. You don't maybe have the genetic part of it, as in you're not missing that congenital part. It's not broken in you specifically right now, so you'll be fine. It's like, okay, well, that should be a good thing, right? That maybe she doesn't have a tetrus of Fallot or one of the other sort of cardiac anomalies, septal defect or whatever else. But then it's like, hold on, but doesn't she, or does she? Have you tested? Have you actually tested for a ventricular septal defect? That's the hole in the heart between the left and the right atrium. No, we don't need to test that. Sorry? You don't need to test that? No. I mean, look, we know there's something wrong, but it's okay. We don't need to test that. You don't need to test that because you don't want to spend the money testing that? Would testing that change the outcomes of what you do for her? Yeah. But we're not going to test that. I'm still scratching my head. Okay, so she can go and do exercise, like aerobics. Oh, no, you can't do hydroaerobics even. No, that would be dangerous for her. But you said you don't need to see her anymore. Yeah, we don't need to see her anymore, but she shouldn't be left unsupervised. Sorry, she shouldn't be left unsupervised, but she's okay. So it's a bit like the seizures. It's like, is she allowed to drive a car? No, she's not allowed to drive a car. Okay, so she's got no independence driving a car. She shouldn't be left alone? No, she shouldn't be left alone. But she's okay. What? Okay, I'm confused. Are you confused? This is the sort of bullshit that I've heard along the way. Ongoing care, I'm going to explain this now, because I've now read all the medical literature worldwide by the specialists in this field who've actually contradicted what some of these doctors, and I'm sure perhaps they might be well-meaning, or they might be rushed off their feet, or not have enough resource, whatever the excuses are. We can give excuses. We know that the WA health system is full of excuses. We know that it's not competent. We know that it's failing. We know that the nurses complain, the AMA complains. We know that there's ambulances ramped up. We know that there's multiple mortalities that are unnecessary, and we have these sad stories of parents who are grieving the loss of whatever family member because there's been failure along the way. I don't want to be that. I don't want to be that person. I don't want to be that person grieving an unnecessary death because someone didn't do the right steps. So what does the research say? Eric Boot et al., one of the major contributors for 22q research, ongoing care. Adults with 22q11.2 deletion syndrome require follow-up, regardless of the age of the diagnosis. In virtually all cases, later onset conditions emerge that require clinical attention. Things happen even as they grow older that you may not have expected or known about. In virtually all cases, later onset conditions emerge that require clinical attention. She needs to be surveilled, looked after, checked on, regular tests. Okay. Knowledge about the high variability in the number and the severity of manifestations and 22q related risks is essential. I would have thought so. That would be common sense. But we put this word common sense out in the day-to-day activities, and we realize there's a huge shortfall and shortcomings. A lot of things aren't common sense these days. A lot of things are dictated by time and resources, finances, and inability to want to do something or be involved because it's too hard. Too hard, you know? That's stupid. Periodic assessments may reveal previously undetected medical conditions, enabling early treatment, and should be tailored to different life stages. The multi-system nature and the developmental complexity of 22q11.2 deletion syndrome demands broad consideration of the signs and the symptoms. That's their language. I haven't written this off my own bat. This is verbatim the quotes from all of the medical literature that exists. So all these really, really clever doctors, specialists, 30 and 40 and 50 years into their areas of speciality, have spent hundreds and thousands of hours researching, working with many patients in this cohort of this genetic rare condition. Should know what the shit they're talking about, don't you think? Don't we trust them? Shouldn't we respect their knowledge and understanding and take this information on board seriously? The main caveat to standard management for normal patients and treatment strategies is that 22q11.2 deletion syndrome related comorbidity demands attention by all clinicians regardless of their subspeciality, with balancing the risk and benefits for proposed treatments. Because of the compartmentalization that occurs in medicine, and we're seeing a neurologist and a gastroenterologist and a dietitian and then a endocrinologist, and then a urologist and a gynecologist, and then you see a rheumatologist, and then you see all these separate people. None of them talk together. None of them work cohesively to understand the crossover of symptoms and all their treatments. Eric Boot, one of the main research contributors to the condition, said that you need to engage with the caregiver for 22q. Involvement of families and caregivers who often provide the monitoring and the oversight of treatment compliance and the results is essential. Enough said. I have an EPG, that's known as an enduring power of guardianship, to support and manage. And in fact, the transition from adult care, as the multiple medical literature journal articles actually espouse, is to consider legal guardianship, ideally before age 18. Not just medical guardianship, but legal guardianship to assist and support, because these patients with potentially impaired mental capacity, learning capacity, intellectual quotients, may not have the capabilities to be able to survive in the very rough and tough exteriors of the outside world, where they can be easily manipulated and sojourned into doing actions and behaviours that are at risk, particularly at risk from alcohol or drugs, of sexual inappropriateness or anything else, financial overburden. There's risks, and they need support. And they certainly need support in a health system where the health system doesn't understand the condition, hasn't educated or learnt about the condition, and can't identify and bring it together in less than 10 years on average to work out that you've got this condition. Now look, a lot of the newer patients, the children who are being born today genetically are being tested, they get picked up. Fantastic. Yay, we've actually had some inroads of success, and that helps the generations moving forward to a point. Just like having 2 specialists in the Children's Hospital, Perth Children's Hospital, that helps the children of Perth, Western Australia, if they've been identified for that condition at childhood. Great, all for it. What about the late diagnosed who have been missed subsequently? What about the transition for those who become adults? Because at 18 years of age from that Perth Children's Hospital, there's nowhere for them to go. Their records don't get transitioned to other specialists. There's no handover. There's no communication backwards from the new specialist to the previous pediatricians or anything in that space. It's like a line. It's like a border. You're crossing the border without the visa and the passport. You don't know what's going on the other side, and you don't have that information. Deaths are most commonly due to cardiovascular causes, by the way. So who do you think is the one area, if you've just heard that statement, deaths are most commonly due to cardiovascular causes? So if you look at all of the data I've looked at all the data, and if you can see that it's cardiovascular, what's the one area of speciality then that you think that should be involved with regular checkups? Cardiovascular, right? The heart doctor. That would make sense to me. Particularly if the patient's got, well, what's Dyan got? She's got orthostatic intolerance, POTS. She sits up, her blood pressure changes by 15 to 20 milligrams. She can pass out, fall over, trip, get dizzy. Her heart rate ranges from as low as 30 up to 230 beats just from lying down, not doing any action. If your heart rate, when you are lying down in bed right now, suddenly spiked to 230 beats for doing nothing but just sitting down and relaxing, do you think you should be concerned? If you suddenly got chest pain that radiated around to your back, caused you to start to sweat, to clutch your chest, to feel difficult to inhale, that your breathing changes, would you be concerned? Of course, I'd be thinking, shit, cardiac arrest straight away. If you're getting angina, if you're getting fluttering, atrial fluctuations, or arrhythmias occurring, would you be concerned? I would be concerned. If your cardiac transport system is not actually circulating to your extremities and your extremities are getting cold and changing color, would you be concerned? I'd be concerned. If your body, which is your cardiac system, is meant to also transport the fluid around your body and you're getting edema full body and it's not actually being caused by anything else, would you be concerned that it's a heart? Yeah, I would be. And yet this is the one area that Dyan actually needs the first amount of help and assistance, because deaths are most commonly due to cardiovascular causes. The lifetime burden of illness is substantial. Now I want you to read that another way. If you're a hospital or an insurer, the lifetime burden of illness is substantial in cost. Yeah, it costs them money. Not the patient's fault, they didn't choose to get born with a condition. But if an insurer wants to save money, if a hospital wants to keep their costs and overheads down, these sort of patients are the ones that are the most complex. But it's ironic, because if they actually got medical practitioners who actually learnt about the condition early and treated the symptoms quickly, that wouldn't exacerbate into the toll that actually occurs on the hospital system. That's common sense again. So the concurrence of medical conditions, multi-morbidity, okay, comparable with that of the general population several decades older. We say this along the way because she is the equivalent, Dyan, who is 50 years of age currently, is the equivalent of my 80-year-old parents or grandparents. An 80-year-old. She's only 50. But the way her body is reacting, the different components and the breaking down from the arthritis, arthroscopy, the whole lot. At relatively young ages, adults with 22q have increased vulnerability to age-related diseases. That means they get elder-aged conditions earlier on because of susceptibility of the way the whole cellular structure in their bodies work, okay? So what we've learned from all the documentation is there's a lot of commonalities, a lot of things to expect, a lot of concerns. Patients need extra time to be able to explore. Very complete medical histories are critical. Doing genetic testing is essential, because then that actually highlights exactly what components and what genes are related. Once you know exactly what genes, and I've been through all the gene literature, once you know the genes that are in the band for 22q microdeletion or duplication. Once you understand that those particular genes are affected, you then look at what do those genes impair. It is so simple once you know that information, because then you look at going, are you having problems with, let's say it's dystonia. Okay, dystonia, a condition where you get blepharism and oromandibular dysfunction, and it fluctuates, and bruxism, and you get affected with your transmandibular joint, and then you get focal dystonia and generalized dystonia. Well, we know the causation of things like that, a bit like the basal ganglion calcification, as all the literature actually espouses to, that affects the signaling to those very specific areas of the body, and why it deteriorates as it gets worse, which also relates to the hypocalcemia that occurs with 22q. The information is there. All of it is there. It actually explains why the body is doing what it's doing and what to look out for. And that's what's really powerful as part of the reading. If you do the education and the learning on this, you learn what your patient with 22q might come across. When you see those signs early on, you can do something about them before they get worse. A bit like Dupuytren's syndrome or Viking's disease, a contracture of the tendons in the hands, which causes them from instead of being flat to suddenly start to curl, and it starts to curl up like this. Sometimes genetically got grandparents have had this condition. It's known in her genetics, it's known with 22q. And early intervention means that her hands won't get stuck into a position where they're therefore no longer movable and could then become unusable, then require surgical intervention, but you can actually do things earlier. Do things earlier. That's again what the research says with a lot of these conditions. By being aware of the condition, you know what to look out for, how to treat it early before it becomes too bad. Common sense. This is all I'm asking, is that we've got to create this understanding. A lot of people go, why do these things happen? Why do the doctors not understand? Because there's no specialist for it. I respect that. I have just dedicated thousands of hours of my life to studying this condition. I've just done a master's degree effectively in this particular condition, and by doing so, I have learned everything about it. So, I guess I'm thinking of that adage, the death by 1,000 paper cuts. One in its own entity is not much to deal with or feels. 2 or 3, they're small, they're irritating, they're annoying. And I know that a lot of patients will experience that, you get a singular thing, you go to a hospital and you have a great experience, or you go to a GP and you have a great experience because it's quite easy, You get a cold, you get a swab, they identify the type of infection, you get some antibiotics and you're on your way. Or you kick your toe, you've broken it, you go to ED, have an x-ray, broken toe, great, we're going to cast it, you put a boot on, 6 weeks later it's better. But what I find that really sucks with these conditions is, apart from the needing additional time, and that's really comes back to this time and resources, a lot of doctors get incredibly frustrated and don't want to invest in, particularly at the GP level, who are appointed as the centralised care of the condition. They don't have the time, but they're expected to be the hub for managing these conditions. And I don't think that's actually fair. How can a basic GP, and I'm sorry, I'm not trying to put down and negate the skill levels, but a basic GP who's got to have a good generalised understanding of a lot of things, but their task is actually to then refer on to specialists. Well, when you can't refer on because there's no specialist to refer on to, the onus comes back onto the GP. And how can the GP do what I've just done, spend thousands of hours of my own time investigating, researching, learning, compiling the information, because there's not even the resources together. And one resource is not enough. I'm sorry, if you just read one article, it's not enough. I'm dead honest and dead serious. You actually need to collate and bring together all of the research, or it's more of the research than just 1, 2, or 10 articles, to actually start to paint the picture, to realise that there's bias in certain articles, particularly in the area of psychiatry in 22q. Because with certain genetic research, and again, it's incentivization, understand what incentivizes research. Big pharma's like this, it's the dollar signs. For a lot of molecular biology or genetic research, if there's opportunity to become the first person to discover something or make connections between certain things, it creates a powerful thing for your professional vitae to actually say that, look, you've achieved, you've found this, you've discovered this. So certain conditions or subconditions in 22q have attracted the attention of certain disciplines, and that creates bias. So you need to actually go beyond the bias and read a collection, a lot of information to understand the overall arching things. And GPs don't have that time, but they really don't. You're not also going to expect that phlebotomists, radiologists, pathologists are going to have that time. And if a lot of specialists don't have that time, aren't going to invest in it, it's on you. The onus is on you, the person with 22q. But if you're the person with 22q and you've already got language and developmental, communication related issues, intellectual developmental, global developmental delays, how do you manage to break through and be able to do that? Okay, I'm just being really real. You therefore rely upon sometimes the people around you to advocate and educate themselves, to become informed, to help you, to facilitate, to navigate through these systems, to actually get to where you need to go and make sure the treatment and the compliance to the treatment is actually occurring. And that's been my role and responsibility. But unfortunately, here's the other conundrum. A lot of people with 22q will not get partners. They may not also have their family around because they become a burden, just like the financial burden on the hospital system, they become a burden on the family or parental units who will put them into care facilities, and they might not have that support to advocate or even to simply care for them. That's a very harsh reality. I don't want to band-aid some of the harsh realities. Dyan and myself are perhaps a very abnormal circumstance. A partnership that's been together for 33 years, for example, was actually quite abnormal in this space. It's a dedication of time, energy, and relationship of love to support each other. But the reality is a lot of people miss it. A lot of people with chronic conditions, more than 10 years, don't have partners, friendships, and relations around them or family. That's just what the stats are showing us. Probably about 85 to 90% of those people with chronic longer than 10-year conditions lose all of that. Sorry. So it makes it even harder for them, the patient, to obtain the support, the information, and the capabilities to be able to. I mean, I've written thousands and thousands of documents, research papers, medical notes, complaints, whatever it might be, to say, hey, Dyan needs support. Now, if I wasn't here, who would do that for Dyan, who is an orphan because her family wasn't there to support her through this condition? A GP who doesn't have the time to be able to even get through all of the parts of the conditions that I need to, for him to write all the referrals. We had many times where the hospital system have said, we need more information in the referrals. Well, more information means more time to flesh all those sort of things out. More tests need to be, it's time. It's time. No wonder it takes 10 years to get to a diagnosis, doesn't it? Now you understand, I guess. Now, along this process, what I've done is I've looked at Dyan, who was diagnosed over a year and a half ago, to work out, well, look, all of the medical literature explains all the specialists that you're meant to see with all the different symptoms. You don't go and see a specialist if you don't need to. You don't go and have a test done if you don't need it, if you don't have the symptoms for it, or it's not affecting your lifestyle. That's fine. That's common sense. I get that. We're not here to do a full body assessment and go, well, let's just check it for the sake of checking it. No, that's not efficient medical practice, and that's not affordable. But if the patient has got symptoms that she has been talking about for 10, 20, 30 friggin' years, wouldn't that make sense to then go, oh, hold on, she's got symptoms that actually match the condition's expectations? Therefore, we should test to make sure that the origin of those things reflect. And when we've done that in hindsight, particularly once we got the original diagnosis, it led to pathways for us to get more testing done. And we started to find things. It's a bit like we finally got a contrast CT scan done of the head. Bilateral calcification of the basal ganglia and the pineal gland was found. Okay. A lot of patients don't get contrast CT scans, they go straight to an MRI. The MRI doesn't pick up. The MRI is not suitable, magnetic resonance imaging is not suitable to determine calcification in the brain. So if your doctor or a specialist has skipped that step to save money and gone to one other test, they've missed out. If you don't do things like SPECT tests and see functional analysis under MRI or contrast MRIs, you won't see certain things. So in Dyan's MRI, she's also found hyperintensities of the white matter, T1, which is conducive between 22q patients, which will lead to migraines and other seizure-like activities. Okay, well, that makes sense, doesn't it? A bit like the basal ganglia thing I was talking about, the bilateral calcification, that leads to a range of signaling and connective issues that affect things like the eyes, the jaw, and the conditions of dystonia. Yeah, okay, so that all makes sense. it's understanding that over 10 years I've been talking about why is Dyan's neck so bad and needs help. And then when you read the literature and it goes, oh, well, CCI, cranial cervical instability. If you do an MRI of the neck and you find that there's problems with it, and we did, and then we found all these impingements and deteriorations and other issues, and it's like, oh my God, your spine's terrible, and you've got scoliosis, and it's like, all right, well, that makes sense of why you're in so much pain. Okay, so understanding the condition allows you to then seek out and understand that should you check for certain tests, should you then confirm certain components, and then can you get treatment, management. It could be bracing, support, medications, it could be antibiotics, it could be surgical intervention, whatever you need is outlined in the test. So that's one of the other steps that's come out of my research over the Christmas period, is to work out what Dyan has had done, what she hasn't had done in relation to her symptoms, and what still needs to be done. The problem with the WA health system is it's centralised in care through the GP, as I was saying, the primary care physician or general practitioner, who is also time poor most of the time anyway. We've got extended appointment times now, which is great. But even just imagine the referrals, 22 separate referrals to 22 separate specialities takes time to write up and to follow those things up. They go into the CRS, which is the central referral system, and then they go out to the hospitals where the relevant specialists may exist. Dyan's care has gone from 7 or 8 separate hospitals and centralised to one major hospital, because as we found out along the way of our journey, several hospitals, and this has been told to us from the directors of those hospitals or the specialist ED consultants or whatever else, we've been told that, look, those hospitals don't have the resources, the equipment, or the staffing speciality to be able to manage Dyan's level or condition. And that's interesting, because it's like, I had expectations. I thought, well, aren't all hospitals going to be able to do this? No. That's another learning curve that you get out of this condition, is to understand that not all hospitals have all of the equipment. Even some, like a simple thing like an MRI, for example. Not all hospitals might have MRI. Also, what strength, 1.5 Tesla, 3 Tesla, etc., do they have the strength of the MRI? Standing MRI. For a CCI and some of the skeletal issues of composition, you actually need to do a standing MRI to look at the compaction related issues. As Dyan's GP said the other day when we saw him, oh, there isn't one. And I said, you know what, there is for animals. What? Yeah, there is. The vets have got a standing MRI. That's interesting. So we don't have a standing MRI for humans in Perth, Western Australia. We don't have specialists for the 22q condition. And because of the way Medicare is structured, we can't go to the children's hospital for Dyan because she's not a child. And we can't also afford to travel interstate to Queensland or New South Wales, where there are some adult clinics available for the condition out of 26 million people in Australia. Remembering with a prevalence anywhere between 1 in 2 to 1 in 6,000 people can have 22q, but we don't have those sort of resources. Look, and I understand with multiple rare conditions, and Dyan's got multiple rare conditions, a bit like the dystonia, that affects about 65 people in a million. Only 65 people in a million will have the dystonia to the levels and expectations of what Dyan's got. And there's other rare conditions. Duprantion's disease is a rare condition. There's even having Stand loss is considered hypermobility, and connective tissue disorder is a rare condition. There's several different rare conditions that Dyan's got, and each one has its own prevalence, but there's lack of specialists and lack of information, lack of resources to get that. And that has a knock-on effect. It has a knock-on effect to access disability services, because disability services require the health system to provide the information that you need as well. And if the health system doesn't understand, how can they provide that to the disability services to get disability help? Hey, catch-22 situation, isn't it? Funny how the term catch-22 is associated with the condition 22q. Go figure. So anyway, over the Christmas period, I've gone through each of the areas of specialities to work out what has been done and what hasn't been done. And it's been eye-opening as well, because, look, I respect specialists have spent an extra bit of time in the area of training as doctors to specialise in their own particular fields for the general conditions that they expect to see in clinic where they operate. And I also respect, just like I said, that certain rare conditions are rare. That's why it's in the name. You can go to rarediseases.org and realise that there's certain conditions, many conditions that Dyan's got, which are rare. And look, we understand that most people may not come across them in their entire clinical experience. Respect that, I get that. But that's why the medical literature is there. And that's why I've got this huge tub, a folder of all of these things. Just to give you an idea. Hold on. So all of this, needs to be dragged along to all our medical appointments because it's got the information on file that they might need to refer to. It crosses over from general guidelines for managing and treating adults with 22q to specialist area reports, medical literature, research, clinical information, genetic testing, what they've actually found. It gives you information on the management and care, case examples, which are really enlightening when you actually go, Jesus, I've read these case examples and gone, and that one's Dyan, and that one's Dyan, and that one's Dyan. There are actually people out there who are just like Dyan. Isn't that interesting? Who have presented maybe later in life with late diagnosis, just like Dyan. Who have also had the same sort of experiences in the healthcare system, just like Dyan. So when I've gone through all the different areas of specialities to update myself as to what needs to be done to formulate a plan, here am I, the caregiver, a lay person, having to do this because the onus is on me. Dyan herself can't do this. The GP doesn't have the time or the skill set to do this. There are no specialists to do this. There's no healthcare advocate or disability advocate who will do this. And then even your care team providers or support staff probably don't have the skill set or capabilities or the knowledge or the time to do this. You might be lucky, you might find one or two, and that's what you really hope for. And a lot of patients aren't lucky enough to have a partner. Maybe their family members have abandoned them. They maybe not have siblings or other supports of people to help them because they've got their own lives and they're all trying to scrape a living and existence together. I get that. These people become very isolated. So this is what I said about reinventing the wheel. If the information is out there, we need to make it more aware. We need to create advocacy. I need you to share this video to other people worldwide. Get them to actually understand the implications of this, the difficulties, the risks associated to this, and that there is hope, that there is information, that there is help out there. And if people could actually source this information like I've spent the time, the hours, the thousands of hours doing so, and researching and bringing it together, there is guidelines and things that can help the patients to actually thrive, not just struggle. To actually give them ideas on treatment and management and preventatively protect them to avoid them becoming one of the statistics, particularly from cardiovascular related issues or many of the other singular unrelated conditions that can actually cause pre-morbidity, okay, very early in age. Now, the other thing that I did as part of my research over the Christmas period of time was not just to go through all the areas of speciality and realize that, look, some have tried. Some have tried in a very basic way, just like they would generically do with any patient that walks into their clinic, and they'll go, well, look, here's my normal bank of tests that I do for any patient. Well, Dyan's just not any patient. And if they're not taking the time to actually do questioning and getting the information and the knowledge, or have the capacity and capability to realize that Dyan doesn't herself have the capacity to know about herself. Interoception, which is for autistics, a lack of self-awareness of internal states. How is she meant to know if she can't even work out if she needs to go to the toilet or if she's thirsty or whether she's hot? How is she meant to know if she's in pain and where the pain is coming from and what's causing the pain? How is she meant to do that? Go on, I'll wait for an answer because she can't. She hasn't been able to. And a lot of autistics, a lot of people with intellectual developmental delays, cognitive abilities or inability to speak, how do they do that? Dyan will commonly use an AAC, an augmented alternative communication device in clinics because it's a stressful environment, and stress and anxiety is a major component of 22q. As the literature says, it actually expressly says that. The geneticist that Dyan has actually written a supporting letter to say, this is part of the condition and you need to speak slowly, be considerate to that, not cause stress, not invade a personal space, take time. But does that translate to what the clinics and the specialists and the doctors can or will do? No. And me as a guardian, and I've got an official guardianship through the public trustees, I've contacted the public trustees because the public trustees are even acutely aware that I have been blocked from supporting and managing Dyan's care in a lot of healthcare scenarios, and that's not right. It actually defies the legal obligations of what that document and that role as a guardianship actually does. Crazy. And that's all to the detriment then of the patient, who misses out on the necessary support and care that she has. So what I discovered, like I said, was some of his tests are superficial or at the earlier sort of stages, basic level, introductory level. But if you don't take the bigger picture and listen to and take the time to actually extract the symptoms and understand that there's issues, it's a bit like a UTI. UTIs, urinary tract infections, can be such simple things. Okay, we can test them and treat them and away we go. So why the hell would Dyan have a complex UTI? It only became complex because it wasn't identified and managed early on. And then why would that complex UTI exist for over 3 years? 3 years. Seeing multiple specialists in this space. Urologists, gynecologists, immunologists, infectious disease, and yet the literature explains all this clearly. And in fact, the literature even explains to the point of going, patients with this condition, and particularly in the hypermobile connective tissue disorder Ehlers-Danlos side, urine tests are not effective in those patients because of their biology. Okay? Which means you can't even rely upon the testing criteria. And even when I've spoken to senior pathologists, they'll go, well, look, if the patient's on 3 antibiotics, antibiotic creams and preventative bacterial medications, and you're expecting a bacterial result to appear in pathology, it ain't gonna work because it's been masked, hidden, protected by those other aspects and elements. That's basic pathology 101. Bit stupid, isn't it? But that stupidity, that level of dumbness, affects the patient's outcomes and then leads to other things. Because once you're dealing with a simple UTI, that becomes a complex UTI that then affects inflammation, pelvic inflammatory, prolapse and pelvic organ prolapse. It can cause other infections throughout the body because your body's immune system has then become weakened as it tries to fight these. You're then becoming more neutropenic. Your white blood cells and all that are starting to then decline. That can create leukemia-like symptoms. It becomes a shit show. So it's so important that the simple things are identified early, treated and managed before they become a shit show. Lucky it's not winter, because if we were getting respiratory conditions right now for her, that would then affect her ability to breathe, oxygenization, and then that can even create more issues on cardiac and strain around that. So what I've found is that the specialists only know the basics and they don't look wide enough, they don't interplay between the other areas of speciality, they don't follow the guidelines and the recommendations that are there for a reason, and they need to take that time or be pointed to that. And you have to point it to them in a gentle way because there is an ego that goes with medical professionals because look, they've spent a lot of time and energy and money becoming a specialist in the field. So you have to tread carefully. It is a minefield as you navigate the interplay of social interactions with egos, attitudes, pomposity, but to advocate and with clarity and in a timely manner, because you don't get much time in an appointment, you don't want to aggravate or negate the situation. It's a very difficult thing to actually effectively navigate. I'm just being real. It is proven to be very difficult and I've experienced that. The other thing that I've done is to work out, well, now that you've got a diagnosis, what do you do with it? Well, there's actually recommendations and requirements for yearly surveillance to protect, particularly as the data, as I read at the beginning, actually explains that, look, as you go along, new symptoms and things will evolve. It may not have existed previously. It's expected. It needs to be prepared for. You need to test for it to ensure that once it comes on board early, you're ready, you capture it and you deal with it so it doesn't become a bigger or more complex deal or become a key contributor to early mortality. So there is a whole range of surveillance that needs to occur. Funnily enough, I think everybody, as you're getting older as well, you do need to have a series of sort of tests. You know, when you're 50, if you're a female, breast tests, mammograms need to be done, or poop tests for your colon need to be done. Certain things need to be done, okay, different age groups. We get that. That's for the normal, healthy population to make sure that they keep on top of their health and well-being. That's obvious, okay? Sometimes there's things that are not obvious. Remember those assumptions? If you see Dyan, who looks like a healthy female, it's funny when I look at these videos back on the channel, but I've had so many people, even carers, go, she looks so healthy, until they've actually seen it in operation and understand all that goes into keeping her healthy and alive. The special diets, the nutrition, the medications, the supplements, the pain management, the traction, the pain relief, the ointments, the creams, the protocols, the avoidance, the missing out, the resting. There's a wealth of things, but you're still dealing with seizures and dystonia and Tourette's and respiratory and cardiac. But people will look at Dyan and go, well, look, she looks skinny, so she must be healthy. Okay, that's right, because she's not fat, she's not morbidly obese, so she must be healthy. Well, that's not an indicator. She's small in size, or she dresses well. Okay, the beauty effect comes in because she can actually wear a pretty headband or brush her hair back. She's got long hair. She must be looking after herself, because the only time you see her is the fact that we've actually gone with personal grooming before we take her out of this environment. She may not have been able to shower for 4 or 5 days, but we're not taking her out into the wild outside of this house until she's clean and looking well presented, because she wants to feel that way when she goes out. So that's a misnomer. It's an assumption. Just because she looks that way, it doesn't mean she is that way or feels that way. Clinical data we collect, from temperature to blood pressure to heart rate to oxygen saturations to computer test strips to look at the chemistry and pH and neuron or whatever else, regular blood tests. Those things are super duper important. But for patients with 22q, a lot of assumptions can be made, and particularly when they don't want to go towards medicine, when they abscond and run away and retract from it, when they can't communicate or they answer things literally, how are you? I'm good, thanks. But without saying, oh, I've got this and that hurting, it's difficult. So the surveillance tests are there for a reason, and it covers a whole wealth of things. There's a whole range of things that need to be done, from dentistry, eyesight and hearing regular checkups need to occur, overall health and functional status, swallowing assessments, capacity to do daily activities needs to be checked, cognition needs to be checked to see if there's been any deterioration, memory loss, ability to retrieve and store information, functional as far as executive functioning abilities also go with that. Has there been any deterioration of things like swallowing with dysphagia? Has there been an increase of pain across other areas? Has there been any loss of function in her systems? All of these need to be checked, just as well as the ongoing electrolytes, magnesiums, phosphates, calciums. Are they in balance? Okay, all of these things need to check. And then we need to see if certain organs are not displacing, moving or deteriorating as they do, as they are known with 22q. So that's been my research. That's been our goal over Christmas, is to create plans for communication, to improve education and awareness of the condition with the health professionals that we deal with, being mindful of their inability for time, lack of knowledge, ego and attitude, and how to actually deliver that, to advocate for Dyan when there's communication related issues, to request and ask for accommodations for her disability needs, not just noise or light sensitivity, the use of an AAC, augmented alternative communication, more time in appointments, slowing things down, enabling and engaging with the caregiver and the supports around her or her guardians to have those in place, to request more testing to get in front of things and be mindful of that, and pathways when people can't access things like EDs or otherwise, how to get to that. Our channel shows you the day-to-day real-life living of a person with disabilities with multiple rare conditions, and particularly 22q11.2 deletion syndrome, their caregiver, their partner, our relationship, and we still have fun and we do other things, but the reality is that's our life. And my journey over Christmas was well invested. I feel really happy about the time I've spent doing it, because it's worthwhile for Dyan with the improving of the outcomes, and it's opened up my eyes to what the problems have been with dealing with and interacting with the healthcare system, where some of the blocks occur, and why I still need to try harder each and every day to keep her alive, keep her healthy, keep her happy, to make sure that she's having her best day, and not for that to be underpinned by people making assumptions, by talking down the fact that she's the person who is so strong and doesn't complain, with a high threshold, high tolerance of pain, who will not present forward but instead step back, who doesn't feel worthy because everybody has found her in her health, because she's been deemed too hard when she didn't choose to have the condition. She's just trying her hardest not to complain and get on with life, and we've been failed because the health system is unaware, because it's rare, they haven't heard of it, hasn't come across their desk, or they haven't spent the time like I have investigating, researching and compiling the information, which is all there, very clear and obvious, and is huge guidelines to help us support Dyan moving forward with her care. I hope you found today's episode informative. It's been a bit longer than I expected. I'm sorry for that, but I hope you've stayed through to the end. Please give me a bit of an encouragement, because it has taken a lot out of me as well to do this. It's exhausting, but it's necessary, it's important, and I will do it again and again, just to know the condition, to be able to do my best to help Dyan. And if you have comments, questions, ideas or suggestions, I'd love to hear from you below. You may have experienced this yourself. You may have had to do these exact same self steps to educate and to advocate, to find out the information, to spoon feed and hand to your doctor or treating team or care team or specialist. You might be seeing these same sort of struggles. You might be a family member who's concerned for your loved ones, seeing them deteriorate, and realize that there is help out there. You just have to work hard to find it, and you have to help them to see the information. And you're responsible as a caregiver and a family member and a loved one, because you're seeing it day to day. You know what's going through. Your statements, your evidence of support will actually make a difference in someone else's life. So I encourage it. If you're new to the channel, please subscribe and hit that notification bell. I really would ask if anybody and everybody could share this video, this one, to educate and get the word out about 22q11.2 deletion syndrome and our struggles and what needs to occur, and that there is hope and that there is help and there is information out there. People just need to be guided towards it and letting it to be applied, and for the egos and the other shit to be put aside so that we can get some support. Thanks very much for your time today, guys. Bye for now.